that I've done, so have to bear with me today. So my name is Dustin Palmer. I work as a therapist here in Tulsa, but my practice is kind of unique because I started one of the first integrated care clinics, I think, in Tulsa, from my understanding. So what that means is that we have primary care, specialty care, and myself all in one building. So it's really convenient for our patients. So let me see if I can pull up my PowerPoint real quick. So bear with me real quick, and hopefully I can share my screen. But all right, now let's see how this is done. Okay, Jenna, I'm gonna have to get help from you. Where do I, oh, here it is, share screen.
Did you find it? The share screen? And
that? Okay, share.
And then press this screen you want to share. Still not quite there yet.
They work?
No, sorry.
Okay, wait. All right. Like I said, you guys bear with me. This is my first time, so do you see it?
No, we don't.
Let me try one more thing.
Okay. If not, you can just narrate it if that's okay with you.
Okay. Do you see it?
No.
Dustin, do you see a green share? There we go.
There it is. Okay, perfect. Thank you.
I had to give my computer permission.
Okay.
Like I said, this is my first time doing this on Zoom. It's kind of funny. I graduated in 2012 where we did nothing on Zoom. So this is new to me. So thank you guys for being patient. I do appreciate it. So let's see now if I can get my slide to work. So this is the Cary Clinic. This is some pictures that I took of the clinic. That is our waiting room, and those are some of our just patient rooms that we have. You know, with my part of the clinic, you know, I will use the waiting room for my patients as well. So it's kind of cool. So when you go to a therapist, people just think you're there to go to the doctor. And then I will also sometimes do therapy in the patient rooms if they have a doctor's appointment. Sometimes our doctors do run behind. So it's like nice if they can just see the therapist while they're waiting on their doctor. These are, our clinic is kind of unique. We have infusion suites. So I'm going to tell you a little bit about the specialists at my clinic. So we have two specialists right now. They do allergy, immunology, and pulmonology. So for some of those conditions, they do receive infusions for treatment. So we have these rooms so our patients don't have to necessarily go to the hospital to get their infusions, that they can just come and have their own private setting to sit and kind of enjoy it with their family or for themselves, take a nap, whatever. I will also use these rooms to do therapy as well. If you're coming to get a treatment and, you know, my doctor, he was a proponent in bringing me on. He kind of said, you know, Dustin, I have the space and I know you're interested in it. So, you know, feel free to do what you want with it. So, but one thing he likes all of his chronically ill patients is to seek therapy because he does know how much mental health affects their illness and how much their illness affects their mental health. So, you know, the infusions typically last anywhere from, you know, an hour and a half to sometimes they're there 7 hours a day. So, so he was So I will definitely just go in their rooms when they're having their infusions and do therapy there, or and then the doctors also come in there to do their office visits if they need an office visit that day. So here's some of the patients that we deal with at the office. Just a list of some of them. I have a few that I'll go over a little more intensely, but the biggest population we probably see at my office is primary immune deficiency diseases. A lot of people are not familiar with these. They are becoming more recognizable in the public eye. We've been talking a lot about the immune system during the pandemic, so it's kind of like, I'm like, yay, people are getting more educated about their immune systems. So, but primary immune deficiency diseases are a group of more than 200 rare chronic disorders in which parts of the bodies.
Huh?
Oh, someone have a question? Okay. If anybody has a question, feel free to chime in. I'd like this to be interactive. So where part of the body's immune system is missing or functions improperly. So this disease is not contagious. It is a genetic disease that is usually in birth or early childhood, or honestly, some of our patients have been diagnosed at any age with this condition. It is, the statistics used to be, it took about 12 years to get a diagnosis. The real symptoms for this condition is just being sick all the time. So we all know those people who are sick very often, and sometimes we think, oh, how can they really be sick that much? Well, there is actually a condition where they are. And right now, the only treatment for it really for a lot of the patients is just called human immune globulin that they receive once a month through IVs. And then now it can be done through IVs or sub-Q. And these patients have a lot of other complications because of their immune system problems. So that is actually probably the biggest population of patients that chronically ill populations of patients that my office does see. Like we said, we have 2 immunologists in our office out of probably like 4 or 5 in the Tulsa metro area. So there are not very many of these, and a lot of immunologists do just like to focus on allergy, so they don't do a lot of the actual immunology part of things. So we stay very busy with these patients. Cystic fibrosis patients. So Dr. Carey, who is the owner of the clinic, he is a pulmonologist and he sees a lot of CF patients. This is a lung disease, a genetic lung disease that is life-threatening. It causes persistent lung infections and progressively limits the ability to breathe. There is, in CF right now, there are a lot of research and a lot of medications and therapies to help these patients live very long and successful lives. Some patients, if they don't take care of themselves and do what the doctors say at a young age, do have to receive lung transplants in the future. But if they are compliant with their medications, they can live a very long life. And that is true with the primary immune deficiency patients as well. So the biggest thing I see with a lot of my patients that I work with is just medical noncompliance and trying to work with the doctor to make sure that they are as educated as they can to do what they need to do to take care of their health. Rheumatoid arthritis. So we see a lot of these patients, I think mainly because of our infusion suites, because my doctors are not rheumatologists, though they do know about the immune system. So this is an autoimmune disease in which the body's immune system, which normally tracks its health by attacking foreign substances like bacteria and viruses, this one mainly attacks the joints. So a lot of us know what rheumatoid arthritis is. One of the big treatments for severe rheumatoid arthritis is infusions. This is usually, we infuse like Actemra, We have a few others like Mckee and other things that we infuse for our patients who do have very severe rheumatoid arthritis. I do often talk with some of those patients as well when they are in the office. Crohn's disease is another one that we see a lot. Like I said, we're not a GI, but we do have the infusion suite. So Rheumacade is a big therapy that they use for chronic Crohn's disease. So, you know, if the doctor indicates or my infusion nurse indicates that, you know, hey, you know, they're having a really hard time and she knows that, you know, they come there for infusion, she might recommend that they see me as well. Asthma is very common, a lot more common than the other things, at least. And we do work with some people with asthma as well to just help them figure it out. You know, for instance, one of the big things right now, I was talking to one of my immunologists today about someone that we mutually see. And she really wants me to talk to the patient because the patient uses medicinal marijuana for pain and anxiety and depression, but it's really affecting her breathing and her asthma. So, you know, she's like, I really want you to talk to her and try to figure out better alternatives to help because it's really hurting her lungs. So these are just some of the issues that we come in contact day to day. So I'm really working with my immunologist to help this patient out and see if we can figure out better uses for that. And like I said, we do see several other different just rare diseases. Dr. Carey, he very much doesn't like to give up on people, and he's one of the doctors that people will see after they've seen everybody else and try to figure it out. One thing about my clinic too is we also have primary care. So we have 3 primary care providers. So a lot of these specialty patients also see the primary care providers for their primary care. So they're just going there all the time. So they might see me for therapy, see the specialist for their specialty condition, and just if they're sick and something's going on, they'll just come to see the primary care, one of the primary care providers. One thing I did forget to mention about my clinic is one unique thing about my clinic is we're not affiliated with any health system. So we're not a part of St. Francis, St. John's, or Hillcrest. We are just our own clinic. So all of my providers, including myself, we just kind of get referrals wherever we can for our patients, like I said. So one thing I did want to touch on a few things that I see with my patients. Physical health problems cause mental health issues. So we see, especially with that first diagnosis, there's a lot of stress that they deal with adjusting to these issues, a lot of struggles that they just don't understand, and adapting to this new, you know, what I call for my patients the new normal is, you know, trying to figure out their new normal now that they have this condition and what life will look like. Because I'm a true proponent in that you can have a normal life. It's just going to look a little differently. That doesn't mean that it's good. It doesn't mean that it's bad. It just means it's different. And we can make the best in that. One thing I see a lot too is family issues, especially with my kiddos. It definitely, if I see a sick kid, for instance, we definitely see that disrupt the family. I mean, it disrupts it on every phase, but you know, I've seen that a lot where the other siblings don't understand, you know, why their sibling is sick, and then there's like jealousy and not understanding behind that, where one kid gets more attention. One other thing you see, you know, you can often see a lot of marital issues if a kid is sick within the mom and dad, just trying to understand how to juggle everything, and that's very stressful. So, you know, at my clinic, I do see kids, teens, and adults, families, couples. I kind of do it all. I like that. It's what I prefer. it lets my right brain work a little bit, my left brain work a little bit. And so, yeah, one big thing that we do see sometimes with our patients and their diagnosis is depression. I have had some of my patients who are chronically ill, be suicidal or at times. So we definitely try to catch that early, if a patient is that way. And that is kind of why my doctors implement that, they see me through their disease progression so we can catch that. And if anything happens, that we get a hold of it really quickly so that they don't have to struggle with that all by themselves. Something that also is big is anxiety. A lot of these patients, especially the ones who have been sick fairly often, have a lot of what I call health anxiety. I don't know if there's an actual term for it, but it's that I like to say it's almost like a piece of post-traumatic stress, but this the littlest sore, the littlest cough, their mind goes to the worst. They just think they're getting sick again, and they think that they're going to spiral downhill. And a lot of times that's not the case, but because of during their diagnosis and their disease progression, they definitely get sick a lot more than the other people. And so they fear that happening again. But usually once they're on treatments, and as long as they take their treatments, they can stay pretty healthy. But we definitely see a lot of that, like what I call health anxiety. And then of course, grief, it is grief with these people is constant. They're always moving in and out of stages of grief with these conditions. A lot of my PI patients, primary immune deficiency patients. Oh,
So cute. She's doing guard dog.
Okay. A lot of my primary immune deficiency patients, they often, for some reason or another, their conditions develop into autoimmune diseases. So a lot of them will end up with RA, with lupus, our CF patients, as their disease progresses, oftentimes these patients get diabetes. So it's like, they had one thing, but now they're adding all this stuff to it. And that grief process definitely continues to cycle through when that kind of stuff happens. And a lot of these patients are at risk for a lot of other conditions. So, that is very scary. And right now, during COVID, they are definitely having a hard time with everything, trying to adjust and understand and deal with quarantine. I am working at my office right now, and of course, just like everywhere else, we're all wearing masks. And I did visit with one of these patients the other day at my office while they were getting their infusion, and this person is they're in pretty good health as long as they get their stuff every week or every month that they need to get it. And they were just talking to me about how they haven't done anything since COVID, and they're just trying to make sure they don't get it because they're so afraid that what could happen to them if they do. And we kind of processed that and talked about that for a little bit. Physical health problems can lead to mental health issues. So we see this a lot too. Adjustment issues, talked about that, adjusting just to that new normal that they do have to experience. Some post-traumatic stress, and that kind of goes into the health anxiety as well. That something might happen, something might go wrong. They think about that stuff a lot. I talked about jealousy with other people. Why do I have to deal with this, and why don't other people have to deal with this? A lot of sometimes can turn into bitterness, towards people who don't have to deal with the struggles that they deal with, especially kids and teens. I see this a lot with, and kids with their siblings and things like that. social skills issues. One thing with the kids that I see, you know, they're in and out of school. None of them are going to school right now. They're all signed up for the distance learning or the virtual school. You know, so due to that fact, you know, they miss a lot on that social stuff. You know, for instance, my primary immune kids, they get pulled out anytime there's a flu pandemic in their school. So they get pulled out for a couple months just for the flu every year. So they're kind of used to this, but it definitely causes some problems with social skills. And then, of course, the biggest one we have that my doctors worry about the most is that non-compliance. You know, not doing what they're supposed to do to take care of themselves and to get better. That's probably one of the biggest things that my doctors will hand off a person to me is, you know, I just need you for them to talk to you and for you to talk to them and figure out what's going on and why they don't want to take their medications or why they're not taking it like they're supposed to. And so, yeah. So one thing I did want to touch on is just barriers to mental health care. Some of the problems that we see with people trying to get the services that they need or would like. You know, one big thing, of course, is finances. You know, one big worry that all my patients have, you know, they're already dealing with a lot of stuff. So, you know, that big worry is, you know, how much is this going to cost me? Because I can't afford anything else. You know, so we try to work with them as much as possible. The fortunate thing is that I tell a lot of my patients is, you know, that mental health is parity, you know, for most insurance companies. If not all of them now after the Affordable Care Act, it's supposed to be anyways, but I can't say I've seen some that haven't been. But one good thing I tell them, you know, once you meet your out-of-pocket deductible or your deductible for the year, this is probably going to be free. So, and they usually meet that pretty fast. But of course, that's always a big concern is how much is this going to cost me? And, you know, I really want it, but I don't know if I can afford it. So one thing at my clinic we really try to do is to work with our patients with their balances and their bills and try to reassure them that, you know, this is the last bill we want you to pay. Like, we want you to pay everything else before you pay us. And due to the fact that we're a small clinic, we don't have to necessarily be as strict about finances like you would see at other clinics where if you don't pay a couple times, you're turned over to collections. Honestly, I don't know if my clinic has ever turned anybody over to collections. A lot of the time, the balance just sits there until we hope and pray that they pay it. So that's a nice thing that we can do because we don't have the big health systems behind us, which allows us a lot more flexibility. Transportation is a big issue to mental health care or physical health care for that matter. You know, for our sooner care patients, they do have sooner ride, which is helpful. But, you know, sometimes there are other patients that don't have sooner care need help with transportation as well. So trying to figure that out for them and try to help them get that transportation they need to get care. You know, one great thing during this pandemic, though, has been this telehealth that we've all been experiencing. If you work in therapy or work in the hospital, you definitely know that, or clinics, that they're doing a lot more of this telehealth, which, you know, kind of eliminates a lot of times that barrier to transportation if they do have Wi-Fi or a good connection. But then again, that's another problem. So, that has been helpful for some patients though. And especially for mine, you know, with therapy and things like that. So insurance is always a big issue, you know, getting these patients mental health care. You know, one thing I've tried to make a point of is that I'm credentialed with every major insurance company that any patient could have. At times that is very difficult. At times I have to make a lot of appeals and find the right person to talk to, but we're social workers, and mental health professionals, so we know how to work the systems a little bit and get what we want, I like to say. So yeah, but I mean, that is a big deal, you know, like a doctor wants me to see someone, but I'm not paneled on that insurance company. So then I have to go figure out, okay, who do I need to talk to get paneled if their panel is closed? And so oftentimes once insurance companies know our setup, they'll let it happen. But if they don't know what kind of place we are and they just think I'm an outpatient mental health therapist, they say they have enough providers. So that's definitely a barrier to some of our patients dealing with chronic health needs. Time barriers. So just trying to find time within all their other appointments. A lot of people with disabilities.
Tonight's game will be shooting at Jacobsen. Our team has been
time barriers. They got other appointments going on. They might have 5-6 appointments in a week. They might have physical therapy. They might have another kind of therapy, occupational. So those time barriers are a big deal, and just making time for it. And like I said, that this telehealth has helped with that as well. I've noticed that for my patients for mental health care. I've had people call me on my telehealth site that I'm using, and they're sitting in the parking lot at another appointment and they're getting ready to go into because they got to wait in their cars. So that's been kind of helpful too for that. Medical barriers. One big thing to mental health care, I think, for people with disabilities is, is the place handicap accessible? Can they get in? Do they have the right kind of, an elevator or something if you're not on the first floor? So definitely those, their physical limitations and possibly getting to a mental health center that meets their needs or somewhere they want to go. I mean, that's a big thing too, that insurance, going back to insurance, it limits who they can see. And sometimes they want to see a specific person. And then just feelings of mutual understanding that, who they're coming to talk to understands them, understands what they're going through. One thing with disabilities is I definitely have come to recognize is that they don't want to talk to someone if they feel like you don't get what they're going through in some kind of way. And that's kind of really helped me as a provider. And I will tell you guys, I'm definitely not trying to hide it from anybody, but I myself have a primary immune deficiency disease. And I myself did my treatments today in my office while I saw patients through telehealth. So I mean, my patients definitely have an understanding that I understand what it's like, and I get it, and it's hard, and it is a struggle, and they definitely appreciate, at least the ones that struggle with different conditions, appreciate to know that I kind of understand and have an idea. And that's very helpful for them. And it does build that rapport, which I feel is one of the big steps in treating mental health is building that rapport with your patient. One thing I did want to talk about too was the concept of ableism. So I'm just going to read this real quick. So ableism is a set of beliefs or practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities, and often rest on the assumption that disabled people need to be fixed in one form or the other. Ableism is intertwined in our culture due to many limiting beliefs about what disability does or does not mean, how able-bodied people learn to treat people with disabilities, and how we are often not included at the table for decisions. So this is very much true, even with some of the patients that I see. They might not have those physical disabilities. Maybe that you can see a lot of my patients deal with what I call invisible disabilities. They look normal on the outside, but definitely things are not the same for them as someone else that didn't have it. So there definitely can be this treated differently at times. maybe by, different people in their lives. One big thing I see with my patients a lot is that, they feel because they've been told that they can't do anything and that they need insurance, so they just should stay on disability after they turn 18, and not even try to go out there and do anything, which they can. But because they've been told, by doctors or by their parents that they can't, they very much get in that mindset that this is their only option, which I try to tell them that's not true. I mean, you can definitely go to school. You can figure out a career that works for you, and be a productive member of society. But so that is definitely an issue. Ableism, like I said, is a form of discrimination. And a lot of people are treated differently. That's why we have the ADA and the Americans Against Disabilities Act for these patients. And one thing with my patients a lot, I talk about, what they're going to say to people, how they're going to explain things to their employers, what are they going to do once they go to the workforce, how are they going to introduce themselves, and because, these patients, a lot of them, they need off at least one day a month for treatments. So how are they going to address that and deal with that possibly without being discriminated against or being let go? And that's really hard. A lot of these patients feel like they have to work harder to prove their worth just so they can stay on at their jobs. Because if they work hard, then the company's not going to get rid of them because they have to leave once a month or be absent once a month. Something is wrong, so we must fix it. I think I kind of touched on that a little bit about, people think that something's wrong with them, and it is, something's not working right in their body, but it doesn't mean that, they can't live a normal life. And it doesn't mean that they need to be fixed in any kind of way. It's just trying to figure out, okay, how can I live the most successful life possible? There's a sense of learned helplessness, that, like I said, they can't do things without other people. They can't go to work. They can't go to school. They're too sick to go to school, so that is a big barrier as well. That they need help from other people to succeed. They have to live with their parents because their mom and dad take care of them, those kind of things. And then one of the other things is not being included during important decisions. A lot of these people in our communities are not thought about. I know the people with my rare diseases aren't thought about. With insurance companies, with communities, and that macro level of social work, it just doesn't happen. And we definitely see that here in Tulsa with our people struggling with physical disabilities. Our transportation is not that helpful for them, our public transportation. We don't have many sidewalks, so that's definitely an issue too, that these people aren't included, and they need to be, because they're part of our community too, every single one of them. So that's something as social workers, we really need to make awareness of, that I don't think is given enough awareness to. And mental health professionals as well, that we make awareness of this for our community members, because that is very important. I wanted to talk a little bit about theory and theories that I use. One big theory that, I often use is empowerment theory. Empowerment theory is a problem-solving approach. Like I said, trying to figure out that new normal for these people in their lives. And what that's gonna look like. This is done through, self-efficacy and building up their psychological self-efficacy, knowing that they can do it, and they have the right to make decisions and their own decisions, and they have a right to, deny care if they don't want that care, or to get a second opinion, or do what they need to do. Developing coping skills for when they are stressed. are dealing with problems, identifying problems, problems that they might be dealing with, and how they're going to cope with those problems. Establishing goals, trying to help them in recognizing strengths by trying to help them understand what their strengths are and what they can still do, and what goals they can take to get there. This is something I do a lot with my teenagers who are moving into a young adulthood. One thing, like I said, I hate to see is for someone to feel like they have to be dependent on disability for the rest of their life if they don't want to be. So really empowering them to figure out, okay, what can I do, and how do I get there, and how do I work through these problems that might come into play later on in life, and how do I get insurance? What is that going to look like, and how do I make sure I'm going to be okay? And one great thing is, like I said, that establishing mutual understanding of, they know that I did it too. They see me sitting there and understand that I had to figure a lot of this stuff out just like they did. And a lot of times I will get, self-disclose at that point and let them know, like, hey, this is what worked for me. Maybe it will work for you, but if it doesn't, let's find out what will, and that's okay. I say that's okay a lot. Some other treatment modalities I use, of course, are cognitive behavioral therapy, person-centered, play therapy, art therapy, motivational interviewing, and of course that peer-to-peer of them knowing that, I have an idea. One thing I never want to say is I understand, because I don't. Everybody's different. So I never want to say, I understand what you're going through, because I know when that was said to me when I was struggling, I didn't like that. So I try to shy away from that. One thing I will say though is I have an idea about what it's like. And I know I was okay with being told that, like I have an idea. I don't know exactly what you're going through, but I have an idea. So let's talk about it. Let's work through these problems. Let's work through these stresses. Let's find solutions. And let's see what we can do to get you on the right track so that you're feeling better mentally and physically. And that takes some steps. So I listed my contact information here. So if anybody wants to write it down and get in touch with me or talk to me, I love talking to people about what I do. I absolutely love the patients I work with. And I love to see when they do succeed and they finally get that glimpse and they figure it out. And then I know they're just gonna be successful. So, feel free to get in touch with me if you have any questions about anything. If you want to see, if anybody wants to see any of our providers, I put our office information on there as well. If you have a patient or a client that you think could benefit from one of our providers, definitely reach out. We have a wonderful team and we all work together for our patients. And, our goal, I feel like, has always been quality, not quantity of care. So we really try to give the best quality of care that we can to our patients and try to help them out for the most success, which I know a lot of the medical environment is trying to move to. And I think that's great because the outcomes can be incredible if you do that. So, but one thing I did want to do is open it up for questions. I think I have a little bit of time left. So if anybody had a question about anything, feel free to ask. Let me know. I love questions. So
feel free to unmute yourself if you have a question for Dustin, or you can type in the chat box and our moderator, Oriana, will say it out loud. Thank you.
So my name is Angelica Exenia, and I had a question about your thoughts as far as if I was thinking about the Bowen theory as far as like the stressors that may impact someone's vulnerabilities as far as their health and opening them up for the health issues that they have, which kind of is on the basis of that theory. What are your thoughts about that? Do you think that, because it definitely brings on the mental health issues, but do you think the stress may have opened up their vulnerabilities for physical issues, medical issues?
That their stress opened up vulnerabilities for their medical stuff.
Yes.
So you're saying that stress impacts their health?
Yes. Like for instance, you were saying how there's some medical issue, that they have are being seen for in the office. And so then you start having other issues. Do you think the stress of just the initial health problem can create more vulnerabilities?
I definitely think there's a possibility for that. I mean, I tell my patients all the time that stress affects the body in so many different ways that I think we still don't understand. So I definitely know that, for instance, if a person is stressed out, especially with my primary immune deficiency patients, and I'm gonna talk about myself for a sec, about how stress impacted me. So I know it happens for my other patients as well. As a very newly graduated social worker, I was trying to do everything, just like we all are. We're very passionate and we get into this field because we're passionate. And I found myself at 3 different jobs. So I was working like mornings here, evenings here, weekends here, just doing it all, and I remember my parents came to me and they were like, Dustin, you're doing too much. I'm like, no, I'm fine. And this is something my young people have to figure out all the time because they don't want to listen to their parents. It's like, no, I'm fine. And sure enough, I was stressing myself out and they knew it. And probably about a week later after they had talked to me, I had 2 pneumonias, 1 in each lung. And then I had to tell my parents they were right. And, I had to eventually quit. Well, at that point, I decided I was going to put in a 2 weeks notice at one of my jobs. And some of my other patients definitely deal with those same kind of things. I always tell my patients it's good to find your balance. What is, when you're not doing enough, but you're also when you're doing too much. And I say, that balance is going to be fluid. It could change day to day. It could change week by week, month by month, but you definitely have to figure that out. Because when they're not doing enough, it can lead to depression, it leads to anxiety. But when they're doing too much, they physically hurt themselves. For me, it was pneumonia. And for some of my other patients, that's what it is as well. So I definitely think that's true. And I hope I answered your question, Angelica. That was a really good question. Thank you.
Yes, you did. Thank you.
Does anybody else have a question about anything that they would like to share or comment? Appreciate comments as well.
This is Leah Jacobsen. I'm actually a co-presenter with you, but I have a question.
Okay, Leah.
Can you talk a little bit about the type of therapy you do when your clients are experiencing bitterness or resentment for their conditions? Are you doing acceptance therapy, or what type of work do you do with them to help at that stage?
I will do some acceptance commitment therapy. I also will just do, some CBT as well. I like to say as a therapist, I think we are all very eclectic in our approaches. But I definitely do some of that, understanding where that's coming from. It becomes a lot of validation at that point to let them know that they are being heard, and that, and I do this, I don't think there's a name for it in therapy, but I call it embracing the suck, with the CBT. Like, I know it sucks and it's going to suck, and that's okay. But that's not going to help you move forward. So embrace the suck, sure, but then tell yourself, in my CBT that I use, and some acceptance therapy as well, tell yourself like this is going to suck, but you've been through hard situations before, and you can get through this one as well. And one thing I tell them, with their conditions is that, and it's true for mental health as well. We talk about mindfulness, it's fluid. They're going to have their good days and they're going to have their bad days, but not every day is going to be bad. And not every month is going to be a bad month. You're going to have your good months too. And you really take advantage of those good days. You remember those when you're feeling, down and out, that you got through it once and you can get through it again. And it is a lot of just challenging those thoughts and really trying to understand where they're coming from sometimes too, and uprooting them, because sometimes it very much is maybe like we go back to the ableism. Someone told them that, and that's why they don't like it. So really trying to just figure out the root of the problem and then trying to challenge those thoughts. But like I said, I don't know if it's one therapy or the other, Leah. I think it's a combination of a bunch of different things that we all learn throughout things. So thank you for that question, and I hope I answered it for you.
You did, and I absolutely love Embrace the Suck.
So yeah, feel free to steal anything, and if anybody would like my PowerPoint, I'm more than happy to send it to you guys. Anybody else?
I just want to say I think your present point has been amazing. Thank you very much.
Oh, thank you so much. So I'm going to unshare my screen now because I know that there's other wonderful presenters.
You did unshare your screen, so you're good. Thank you, Dustin.
I'm good. All right. Thank you for your help with this stuff.
Thank you.
Who do we request a copy of your slideshow from?
You can, if you wrote down my information, you can email me, or if you would like, I could send it to Jenna. And I know Jenna has all of your contact information, so she can share it as well. So
Okay.
It works.
Thank you.
Thank you.
All right, thanks. So our next presenter is Leah Jacobsen. And Leah, would you mind describing your disability a little bit and introducing yourself?
Of course. Can you hear me?
Yeah.
Yes.
Wonderful. I'm Leah Jacobsen. I am a social worker, a recent graduate from University of Michigan. I did not begin my career that way. Back up, sorry, my disability. I am legally blind, and I also have chronic illness. I have a kidney disease on top of it. They're both caused by the same gene mutation. I just got lucky. And so I've been blind my whole life. I say blind, I'm legally blind. I can see a little bit, but not much. And so I started my career in politics, and I worked for the White House and then was appointed at the Defense Department working in health affairs, working to create a health risk assessment for the entire military health system, and was kind of introduced to trauma that way. And then I left defense for a while and was at the Peace Corps launching the First Ladies program, Let Girls Learn, where we were expanding access to education for girls all around the world in 65 countries where Peace Corps volunteers served. And we were, a lot of that work actually involved health work. Because a lot of the barriers to girls getting education were health related. That would be pregnancy, that would also be not having access to clean water. And so we were trying to address some of those health barriers to be able to expand their access to education. And then I decided that I wanted to make a career pivot. I had started volunteering with rape survivors, and I really loved the work, so I went back to school, and I was working with children who are sexually abused and their families, implementing trauma-focused cognitive behavioral therapy with the family unit to try to help them heal and come back together. And so I have a lot of varied experience, but my favorite work is trauma. And so I'm going to touch on it very briefly. There should be multiple courses, and I'm doing it in like 10 or 15 minutes, but let's do it. So this also is my first Zoom, my time presenting. So one second. I'm trying to share my screen, but it says that it's disabled.
I just gave you access as a co-host, and so it should be a green button at the bottom.
Oh, it looks very different now. Perfect. Okay. There we go. Sort of. There. Okay, is it good now?
Yes.
Wonderful. So what is trauma? In the DSM-5, so it's going to be somebody who has been exposed to death, has been threatened with death, has been threatened with serious injury, or has experienced or been threatened with sexual violence. And this can be either direct or witnessing or having a close friend experience or relative experience it. And as social workers, it can also be through hearing repeated cases of trauma, so vicarious trauma. Why do we care? How does this apply to people with disabilities? 80% of people with disabilities have sexual trauma. And as Dustin was talking about, trauma can also affect people with chronic illness, which fits under disability. And also hearing that you have an illness can be traumatic because you can be faced with your mortality and all of the illnesses. And a lot of people with disabilities became disabled through a traumatic experience. So a lot of different situations make people with disabilities more vulnerable. A lot of people with disabilities are in institutional facilities. This can include nursing homes. This can be homes for for developmental disabilities or cognitive disabilities. People with disabilities often have less say over their lives. They often do not get to make the decisions that influence their lives, and thus they have less ability to protect themselves from trauma that they may encounter. Some people with disabilities may be nonverbal and may not be able to express that they are not consenting or make noise to get the person to leave them alone. People with neurocognitive or neurodevelopmental compromise can be at much more risk because they can be more impulsive, or they might not have the judgment to be able to keep themselves in a safe situation. A lot of people with disabilities, well, a fundamental of humanity is wanting to belong. And when somebody has a disability, they often don't belong as much. They don't have as much social acceptance. It's harder to make friends. It's harder to keep friends. There can be isolation. And so wanting to be socially accepted can definitely put people at more of a risk. and they might be less likely to be able to stay away from unwanted attention. I can say being blind, one problem, can be being able to identify the person, the perpetrator who's hurt you. And so I was assaulted, for example, once, and I have no idea who it was. It was a random person on a street. And so that gives perpetrators much more feeling like they can get away with things. And so people with disabilities can be an easy target. It can also be difficult for some people with disabilities to identify a safe place to turn. And so one example, I had a client who was a 10-year-old girl, and she had been sexually abused. She had also been in and out of the foster care system. And the first day I saw her, I walk into the room and she goes, "You're blind," really loudly. And I told her she was right. And so I pulled out the book for us to talk about therapy. It's called Welcome to Therapy. And we were going to talk about what it was. And I got to the part about it being a safe place and about confidentiality. And she cut me off and she goes, "This is not a safe place. There's no bodyguard here or security guard." And that to me told me that in her mind, the only safe person was a security guard. So when she couldn't identify other safe locations and other safe people that she could turn to, that meant that she was going to be less likely to be able to keep herself safe. People with disabilities, some can have more trouble securing help. And so whether that's they don't have the mobility to be able to get help, or they don't know who to turn to, or they don't have money so they're not able to have phones to be able to call somebody for help. Another issue is fearing blame. So a lot of people with disabilities can blame themselves for everything in their lives, right? They sit with themselves and they can feel like they should be able to do more. Or so that when you're already used to telling yourself that you can do more and you should be able to do more, and then you're made a survivor of a crime, it can be easy to say, "I should have been able to stop that. It's my fault. Maybe I didn't do enough to prevent it." There can be issues with having difficulty defending oneself. So if you're weak or if there are mobility issues, self-defense can be difficult. And a lot of people worry that they won't be believed, especially people, I mean, this is common through our entire culture, but especially within disabilities, people who have cognitive disabilities are so mistrusted with what they report in general, because sometimes they aren't accurate, that they can just believe that they won't be considered accurate. And so for this and so many other reasons, the disabled population is much more at risk to experience trauma. So what does trauma look like? It can look like so many different things. When the brain goes through trauma, the person goes into survival mode. And so their body is flooded with hormones, and they either fight, flee, or freeze. And so because there are so many different reactions that could happen, and this is part of the reptilian brain, so the person has no control over which reaction they have. But because there's so many different types of reactions the person can have, there are also a lot of different ways that trauma can present afterwards. So sometimes, especially if trauma happens while the person is a child, there can be developmental delays. The emotional growth can kind of get stunted at the age in which the trauma or repeated trauma has occurred. Another thing that can happen is hypervigilance. And the person is always looking around the corner for what could be a problem and always trying to stay safe. And when you're hypervigilant, there can often be an exaggerated startle response where the person will jump very easily. And always, if there's a sound in the middle of the night, that can just really put people on edge. Another issue can be inattention or difficulty focusing. And this can look like ADD and ADHD in some people. This can just look like people spacing out or dissociating. But there are a lot of different ways that it can present. Excuse me, sorry. It can also result in self-destructive behavior. And so we see a lot of self-harm. And this can be even more pronounced with people with disabilities, I found, in that they already are struggling with their bodies. And now you're going to add to it that their body just went through trauma. And that can be really hard. They can also involve other reckless behavior. Something that Dustin talked about a lot is you get a lot of anxiety and a lot of depression. And I find that anxiety and depression already come so frequently with disability, whether it's feeling isolated and causing depression, whether it's a conditioning being degenerative and thus causing depression, knowing that it's going to get worse. That already lies so frequently with people with disabilities. And anxiety, I know for myself, for example, every time I put my foot down, what if with my cane I missed a step and I could just fall, right? There's always that unknown, and there's that anxiety of not knowing what's around you and who's around you. And so there's just this inherent anxiety, and then you add trauma to it, and it can just really be exacerbated and become life-altering. You can have some people become irritable or become more aggressive. I saw this a lot with children. I see it also with resentment for why they had to be the people going through it. And also it can be aggressive in trying to push the person away from you so that you're not getting hurt from more people. Probably one of the most common things is intrusive thoughts. And these can come in the form of flashbacks. These can come in the form of just recurringly thinking about the person. This can come in the form of having nightmares. And so those intrusive thoughts are even getting in the way of sleep. And there's a lot of sleep disturbance with trauma. And so like one client I had, for example, would call always in the middle of the night. And she was an older adult. She was chronically ill and was in her bed probably 23 hours a day. And her caretaker was sexually abusing her at times. And so this was on a hotline experience, and so she would not give me enough information to be able to report it. So there was nothing I could do to stop the abuse. And so a lot of what we did was safety planning. And it was really difficult, but she would get very angry at times and just start cursing at me because I wouldn't get her out of the situation, and I couldn't get her out of the situation, but she also would not give the information in order for me to do so. One of the other symptoms that we deal with a lot in therapy is distorted thoughts and self-blame especially. So the distortions of whose fault it is and what is safe and what is consent is a lot of what we deal with in therapy. And then one of the other big things is people not feeling as interested in pre-trauma activities. And so I had a client, for example, who came in for self-harming, and I found out that she had been sexually abused. She was a teenager. And she had been really into writing music and creating music and singing before, and she had not written a song or like performed ever since her trauma. And her mother couldn't figure out why she was hurting herself and why she wouldn't create music. And with her disability, creating music had been her one outlet to feel understood. And so not wanting to engage in that anymore because she just was frozen in the time of her trauma. She also wasn't getting an outlet for all of her feelings, and her anxiety and her depression were building to the point where she was harming herself. So these are all the symptoms, and there are plenty of more, right? There are so many different ways that trauma can show itself. But when we're dealing with the population of people with disabilities, it can be really complicated to diagnose. So when somebody has a disability, determining what symptoms are from the disability and what are from the trauma and what are just symptoms from something else in life is really difficult sometimes to untangle. And then there's diagnosis overshadowing, where symptoms are mistaken. And this can happen especially in like chronic illness or for example, I had a client who had served in Afghanistan. He had served 3 tours, and he had been blown up in a couple of IEDs. And so he had difficulty walking. And he started having, he was having flashbacks. He was having all kinds of difficulty. He was having nightmares. But untangling what was from the depression of seeing his friends die and feeling guilty for surviving versus what was coming because of all the pain he was in versus what was coming from PTSD itself was very, very difficult to untangle. And then another thing that's complicated, and this is one that we as social workers have a lot of control over, is making assumptions and healthcare providers assuming that our issues are because of disability and not necessarily because of other things that could be happening in our life. So if I come in and I'm depressed or very anxious, somebody might assume that's because of my blindness or my kidney disease. And that would not be an unfair assumption necessarily, but without asking the proper questions, or if the proper questions are asked, you could reveal that I had experienced trauma as well, and perhaps that was contributing to the symptoms. And so I think a lot of assumptions are made about what disability does and what impacts it has on mental health, and that can overshadow what traumatic experiences people could have experienced. So what can we as social workers do? One of the biggest things is to try to use trauma-informed practices as much as possible. And that can involve micro practices and that can involve macro practices. So training all staff in your organizations on what trauma looks like and how to address it can be really important, so that even the people feel very supported by the receptionists at the front desk, that they know if the person is spacing out, it might not be because of drug use, though it could be. It could also just be that the person is dissociating from a trauma thing. If somebody starts becoming belligerent, again, that could be trauma related. And so being aware of that and having the whole staff understand that can be really supportive to clients. Creating a safe environment is really important. And Dustin talked about part of this where we're talking about making sure that your client with a disability can even access your building. Is there an elevator? Is there a place for somebody to sit in your waiting room if they're in a wheelchair? Are there things that somebody who's blind could be running into, or are there clear paths? So part of this can be very much of a physical environment. And then also creating a safe environment emotionally. And so for someone who's blind, this may involve the therapist or even a service provider in a more of a macro or meso organization describing what the room looks like to a client who's blind, or asking questions like, what can I do to make this easier? Making it feel safe and that they're not imposing by needing extra services. And one important thing is to really use trauma screenings as much as possible, because you never know if your person has experienced trauma. And if it's somebody with a disability, which is 16% of Oklahomans, 80% of them have probably experienced sexual trauma, much less all the other trauma in their lives. And so it's using these screenings to make sure that you're not missing something and that assumptions aren't being made is really important. Dustin talked a lot about using empowerment theory, and this is so important. It is so easy for people with disabilities to say what they cannot do and for them to blame themselves for what happened. And so talking to them about, well, what did you do when you were hurt? When you were dealing with all of this and you still came to my office to talk to me about it. And so pointing out the strengths of the person, and trying to focus on those and bolster those up and try to make the person feel more empowered, both in their healing and in having the situation not recur. Dustin also talked about, there's a lot of overlap, which is wonderful, because we're talking a lot about the same populations, involving the client in as much of their services as possible, having them feel empowered to be an advocate for themselves and to say what is going on, and having them heard is so important. Another big issue is asking open-ended questions and not assuming. So giving them room to tell you what is actually wrong. Is their anxiety today being caused by some bad memories they were having from when they were hurt? Or is it being caused by their disability? Or is it being caused by feeling extra disabled when they were hurt because they couldn't help themselves? So is it an intersectional thing going on right now? Or is it one, or is it the other? Or does it have nothing to do with, they're just anxious because their in-laws are coming over tomorrow, right? Like, it can be so many things, and not assuming. I have one friend who is blind, and she goes to her therapist, and every time she brings up a concern of hers, her therapist goes, well, of course, because you're blind. And she just feels so unheard and misunderstood, and like her blindness is what her therapist thinks is what is wrong with her, and that is not why she came to therapy at all. Safety planning is a really, really big thing. It's a big thing in any therapy practice, but especially when people have experienced trauma and feel helpless, it can make them feel so much better. And when they have disabilities, this can involve thinking outside the box, because they may not have the same ability to keep themselves safe. It may have to look very different. But safety planning is absolutely crucial. Providing accessible resources is really, 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 really important. This can be forms and having accessible forms for your clients. This can be transportation for your clients and helping them be able to get transportation so they can get help and so they can be served by you. This can be, if you work with videos, which I often do with my clients, this can be finding ones that are audio described, or I work with pictures with my clients a lot. But if you're using pictures or diagrams, how do you make them so they are tactile or in Braille? Having interpreters on demand, so that if you have a client who's deaf that wants to come see you, that they're able to. Being able to meet clients where they are is more difficult with people with disabilities sometimes. And it's even the more important, because we're such a marginalized community that people with disabilities need services from social workers so badly. And so we need social workers to be trying extra hard to make their services accessible, and also to have social workers reaching out into the community in places with people with disabilities that might not have access to resources. And so going to churches and asking, do you have any clients with disabilities that need services that are in their home and aren't being able to get to offices? Going to nursing homes and saying, are there people here who aren't getting their needs met mental health wise that could be experiencing trauma and could have no resources to be able to reach out? So one big thing is, so a lot of what we talk about in social work is that it's our obligation to educate ourselves and not to rely on the client to educate us, right? Like our person with a disability should not be the one token person with a disability in our lives that's going to tell us all about disability, or the one person of a specific race or of a specific sexual orientation should not be the one explaining to us what their lives are like and what all the difficulties are and how it affects our lives. We need to educate ourselves to some degree so that we can be culturally competent. And so educating ourselves is really, really important. And you can educate yourself, but you don't know anyone's experience. And as Dustin was talking about, not saying I understand or I know what you're going through. You don't know what the person is going through. And so asking a lot of questions and allowing them to share with you their reality and not making assumptions about what that is really, really important. And so that's important for everyone, especially for disability. And then when you come to trauma, so many people who experience trauma are invalidated and they feel dishonored and like control is taken away from them. And so allowing them to tell you their story is going to empower them and make them feel less helpless. So it's therapeutic in and of itself, allowing them to tell you their story. And I think the last one, and the biggest for me, is to be flexible. So once you ask your questions and once the client tells you what they need or what they're feeling, there are always ways to do it. There are always ways to make it work. And so being flexible, you know, you may be used to describing CBT by showing a picture of a triangle. But if you take 3 pencils and put it on a table and put them in the shape of a triangle and have the person feel it and move their hand to each corner when you're talking about thoughts, feelings, and behaviors, you can do the same thing. And so being flexible to and thinking outside the box to be able to meet your client's needs. And for example, EMDR. So EMDR is a very common trauma therapy. And it involves taking a light and the person following the light with their eyes. And that was the original. That does not always work, especially if you're blind. And that therapy has thus transitioned, and now there are paddles that you can do with your hands, and there are beeps that you can hear in your ears to do that type of therapy. And so just as that therapy has become more flexible so that it can be used with more people, we need to make sure all of our therapies are doing that so that when we reach out to people. As I said, this is kind of short, but I would love to open this up to questions. Actually, let me jump to this last slide. It's resources that I thought might be of use. The first one especially is really wonderful, talking about the intersectionality of trauma and disabilities. And if you have any clients that are dealing with that, it's a really great toolkit. Just in general, the National Child Traumatic Stress Network, National Child Traumatic Stress Network, which is that top resource, is a wonderful one. They have so many different handouts that can be used to provide information to clients about trauma and disability. And then also my contact information is listed at the bottom, my email address. So you can feel free to email me with any questions. If you'd like a copy of this PowerPoint, anything like that, but my email is for free use. And then I would just like to ask if anyone has any questions or comments.
And please feel free to use the chat or unmute yourself if you have a question for Leah.
Hi, I have a question. My name is Sam. I'm with Family and Children's in Tulsa. You talked briefly about sexual trauma, and I was wondering, is sexual trauma only defined by being sexually mistreated by somebody else, or could a sexual impairment based on a disability or a medication or some medical issue also be sexual trauma?
So sexual trauma can be obviously being directly hurt. It can be witnessing hurt. It can be caused, so sexual function impact created, like sexual malfunction caused by a medical condition that is traumatic.
Okay.
Could be. And so like testicular cancer that could cause trauma and could cause sexual dysfunction could be an issue. It can be life-changing to have sexual issues. But I don't know that it would qualify under trauma in the DSM-5, even though colloquially I would use it.
Okay. I was just wondering, kind of linking what was said earlier about just hearing that you are disabled being traumatic, and hearing or acknowledging the fact that you might have a sexual dysfunction itself would be traumatic. And I was wondering if, a working definition would work here, and it sounds like it would.
I would say traumatic when I'm speaking, but if we're going for textbook definition, it would probably be life-altering,
Sure.
As opposed to actually traumatic. Yeah.
Okay. Thank you very much.
Of course.
On it shows that the chat is disabled. I didn't know if that was just on mine.
Oh, I am so sorry. I will try and fix that. But if you are comfortable, could you just say your question? I'm so sorry.
Oh, I don't have a question. I was just.
Yeah, it's disabled for me too.
Oh dear. I'm so sorry, everybody.
I just switched a setting, so it may work now. Okay, Andy Hamilton just said yay. So I believe it should be working, but if it's not, let me know.
Wonderful. So sorry about that, guys. So we're still waiting for our next presenter. So if we want to have a bit of open dialogue until he can join us, that would be
I
fine.
have a question.
Oh, okay, of course.
Someone said, what age group do you prefer to work with?
Okay.
I think that's towards you, Leah.
Wonderful. Children are actually my favorite. And I like working with everybody. So when I went to University of Michigan, I wanted to work with children, and I got really worried that my blindness would be an issue, that a child who had experienced trauma might do something non-verbally that I didn't see, and then my blindness just got in the way of preventing them from getting the treatment that they needed. And that was really daunting to me. And if a child has already experienced trauma, I certainly didn't want to be the thing in the way they're getting treatment that would be helpful to them. And so I started contacting a lot of blind social workers and psychologists and psychiatrists and everything to get their sense. And Each one had a completely different take on it, which was interesting. One told me that he felt the most disabled when he worked with children. One told me that he wouldn't do anything but work with children. And there were some in the middle. And so when I worked with kids, I was a little nervous, and it ended up working really well. I had these two boys that were had experienced abuse in their life, and they were the biggest jerks in the world. They were 9 and 11, and nobody liked them. Their teachers didn't like them. None of the kids in school liked them. The parents of the kids in school didn't like them. They were just kicking each other and punching each other and spitting on each other and cursing and not behaving at all well. And I walk in the room and they start throwing things, and I explain to them that I'm blind, and so I can't get out of the way if they throw something because I can't see it coming. So I'm going to need them to not do that. And they stopped instantly. And then they had a toy, and I didn't know what they were doing with it. And I said, "What's that?" And the boy comes over and he puts it in my hand, and he takes my other hand to feel the parts of it and explains it to me. And I'm just like, wow, this child has empathy. This is something we can work with. And this is something that wasn't being shown in other environments. And so I really enjoy working with children. I'll say I worked with a 3-year-old who was sexually abused with a disability, and at age 3 with a disability, her verbal skills were not particularly strong, and that can be a little difficult in assessing trauma when there isn't the ability to communicate. So that probably isn't my favorite that young. I think it just is challenging for anyone at that age to express what happened to them, and then you add disability to it and it just becomes a lot. But I love working with children. They're so resilient. They're so able to find positive ways of moving forward. And they haven't had time to layer on a ton of poor coping mechanisms that makes healing from trauma even more difficult. And so I'd say children are probably my favorite. And they're also the most painful to see go through pain. They're the only clients I lose sleep over, my babies that have been hurt, because how do you hurt a baby? Any other questions? I actually have a question for any participants who might be willing to share, which is what made people want to attend these sessions? I mean, I know everybody needs EUs, but are there specific reasons and things that brought you here and where it's resonating with your clients?
I'd like to answer that. I really did this for the CEUs and didn't think I was going to be that excited about it. And I will tell you, I am so glad I did it. I'm so glad I listening to this. I work in a hospital setting. So I'm a manager of other social workers, and I think the things that I'm hearing will help me help them work with other patients. I've just been extremely impressed, and I'm glad I'm here.
We're glad to have you.
Amy in the chat said that she works with adults with several disabilities, low IQ and physical disabilities, and she's been looking for something, and that this has been amazing.
I would like to say I work in child welfare, and I work with kiddos with developmental disabilities. And I am such an advocate for kids in child welfare systems who have developmental disabilities, and oftentimes they come from hard places, like you talked about. They've been abused and neglected. So that is what has brought me to this forum. And I so appreciate you and your story, because it is so inspirational that you are a disabled individual and that you want to help others with disabilities. I am also a mom of a young man with autism. He's 22 years old. So I understand what it is like to be a mother of an individual with a disability, and how hard it is sometimes to work with systems that are not always easy to navigate. So
Really?
thank you.
Thank you.
This is Joe Marshall. I was wondering if there are certain resources that you're suggesting to use when you're working with the blind.
So there are resources online. You can literally Google transferring materials into Braille. And so what I tend to most advocate is getting the same materials that you would use with other clients in Braille. I would ask the clients when they come how they would like assistance getting back to the room, if they want any assistance, and describing the room to them and making sure, like, is there anywhere in particular that would make them feel better to sit? And then having information in your office about any paratransit that's available in your area, it would be really helpful because we can't drive. But I think for the most part, except for pictures, which you may need to verbally describe, it should be the same type of treatment. It's just providing resources. So for example, making sure that your forms are fillable on a computer, because they're not going to be able to handwrite out forms, and offering to email them to the people beforehand. If they are Adobe images, then the images can't be read often by the screen reader, and so those aren't helpful, and so then they have to get somebody else to help them fill out the forms, and that's no longer confidential, or they're taking up time in their appointment that normally would have been for therapy, and they're not able to get those services, and they feel like they're making you go out of your way to help them. So that kind of doesn't make the power dynamic go so great. Like, it already puts it off kilter a little bit. So those are the first things that come to mind.
You also talk about some of the accessibility devices that we would be using. I'm also blind. And I was thinking about some of the computer type things that we use and some of the apps and things of this nature.
Like
JAWS.
Right. So I mean, just ensuring that forms that therapists hand out would be accessible would be my biggest thing.
Yes.
Yeah, I feel like, so it's, as a social worker who's blind, like going through school, there are a lot of diagrams and models that we kind of miss out on, or kind of try to cobble together by people reading them to us. So I mean, that part, it affects social work students as well.
Okay, our next speaker is ready. Leah, if you would stop screen share. You're okay. And Dr. Mckee, if you're ready, we should be ready for you in just a second.
How do I do that?
There should be a button near the top that says stop screen share.
Huh, there should.
Ah, perfect. Thank you so much.
Sorry about that.
You're totally fine. Dr. Mckee, are you ready?
Yeah, if you can allow me to share screen. I don't know if you're the host or not, but yeah, I can't share it right now.
Okay, let's work on that. Hold on just a second.
Sure.
I've made you co-host, so I believe you should be able to do it now.
Okay, perfect. Okay. let me get to the PowerPoint here. Okay, are you able to see it?
Yes, it looks great. Thank you.
Okay, well, thank you for inviting me. My name is Michael Mckee. I'm an associate professor at the University of Michigan, and I'm with the Department of Family Medicine. So I have a bilateral hearing loss. I'm profoundly deaf in both ears. I do wear a cochlear implant on my right side. I generally, sometimes not always, I do have a hearing aid in my other ear, although I had a bout of vertigo and it seemed like that seems to be exacerbated with the hearing aid. So I have a lifelong experience working with the deaf and hard of hearing community. And so that helps me to relate and talk about some of the healthcare barriers and some of the things that we see, not only from a research standpoint, but health in general and healthcare points. So what I'm going to be doing, and I was asked to talk about some of the issues that come up commonly for the deaf and hard of hearing population, but also just talk about some strategies and some hopeful solutions and give you some ideas on how to manage that. So let's go ahead and get started. Okay. So I don't have anything really to announce. We have some research funding, so we've been very fortunate to have some support from NIH and also from NIDLR, but otherwise I don't have any other commercial interests to disclose. So I'm going to really talk about some points here. First thing is really talk about how hearing loss affects healthcare access and use. The second thing is really talk about some of the techniques that we can do for in-person and also telephone communication. So I mean, obviously with this pandemic, we've moved a lot over to a more of a virtual care environment, but that also can exacerbate some of the disparities as well. And then talk about how we can empower, educate deaf, hard of hearing individuals and clinicians how to communicate effectively. And then lastly, just talk about some of the tools, resources, and some upcoming technology that's available for these individuals. So this is an infographic that we developed and really just kind of help understand some of the barriers, some of the gaps that we currently have. So I tell a lot of my colleagues, people in health professions, you're going to come across these individuals. So there's 17% of our population right now has some degree of a hearing loss. So this is a common thing. We see it often in our clinical communities, schools, you name it, you're going to come across these people. But hearing loss has been identified as being an enormous barrier, healthcare barrier, in terms of when we think about communication. So the other thing that's important to recognize is that we often propose amplification as being one strategy, but keep in mind that some of these strategies are really largely out of reach for many people. And when you think about a pair of hearing aids, it's actually going to be the third most expensive thing you're going to buy after a house or a car. So unfortunately, most insurance plans do not help or cover this. So it's an enormous cost. And so that's something that we struggle try to get covered as well. And so it's not a surprise that many individuals with hearing loss often are not able to get hearing aids. And so roughly about 1 in 5 individuals have them. And so there's a long way to go to really think about from hearing health equity. And then what does that do from a healthcare use standpoint? So when you think about from an emergency department business, there's roughly, what we have found is that there's a 17% higher risk in terms of going to the ED compared to their hearing peers. And then when we talk about those who also identify having communication trouble, trouble hearing among the people who have hearing loss, 32% greater odds of having a hospital readmission within the 30 days compared to those who don't report that. So unaddressed hearing loss has huge impacts on their healthcare use, the quality of care that they're going to receive as well. And then the other thing is there's certainly higher healthcare costs for untreated hearing loss when you compare to those without hearing loss. So there's a lot of things that we can do, hopefully do better. So I try to get people to be more aware on why it's important to focus on deaf and hard of hearing patients. I mean, we know we're going to come across them. Is again, 1 in 6, 1 in 7 patients have hearing loss. But the important thing to recognize now, over the last 10 years, we have developed, we have actually now come across a lot more very insightful research literature showing there is a widespread impact on not only just the psychological, social, psychosocial, but now we're moving into medical conditions and cognitive decline. So cognitive decline is one that a lot of people are very interested in because what they have found among individuals with a later onset of hearing loss are roughly about 30% higher risk for developing cognitive decline compared to those who don't have hearing loss. So, so that is something that CMS, health insurance, also healthcare providers, I mean, a lot of people are starting to pay attention to that. So what can we do about it? Because it does have a very costly, very devastating sort of sequence of events. And so that's an area where a lot more research is now coming about. And then the other thing is health conditions. We have found that hearing loss is also associated. We still have to find out the causality part, but associated with a variety of conditions. Some of the common ones is cardiovascular disease, diabetes. We also see it with hypertension, and then certainly a lot of the mental health disorders too. So I want to talk a little bit more in depth about the access to and utilization of healthcare. So some of these I mentioned a little bit, but I want to cover these 4 articles, which I'll show in a second. So the first one up there is by Dr. Genther, was done a few years back, and it's been about 5 years now. But he actually found that really the severity of hearing loss is really tightly correlated with the risk of hospitalization. So what he found is that compared to their hearing peers, even people with mild hearing loss, were 16%, they had a 16% increase in hospitalization compared to the hearing peers. So even those with mild hearing loss, it's important, we need to pay attention to them. But when you go up to moderate, it's 21% higher. So obviously, as you go into higher gradients, especially with the severity of hearing loss, we see that also ties with higher hospital or inpatient use. The one below with Dr. Chang was another one that I mentioned just a few minutes ago, and was also really helpful to know that if you have trouble communicating and with a hearing loss, your hospital readmission goes way up. So it was found to be 32% greater odds of being readmitted. And so that was important for especially Medicare. It's now trying to figure out how to manage that. And hopefully we can get better coverage for some of the hearing aids as a result of that. The other one by Dr. Reed and his team found that unaddressed hearing loss compared to those who don't have a hearing loss, remember it's unaddressed. So unaddressed hearing loss, their healthcare costs on a per capita basis over 10 years is $22,000 higher than their hearing peers. So again, higher costs, higher inpatient, not always appropriate healthcare use. So that does affect their healthcare use. So what do we do about it? So my team and Dr. Mahmoudi, we actually looked at another data set, and those who do address their hearing loss, we looked at those who had able to get hearing aids and compared to those who were not able to get hearing aids, so unaddressed versus addressed. And what we found is that those who have addressed hearing loss we're able to have a 9% reduction in their emergency department use and roughly about 8% for inpatient use. So this was the first time we were able to see if you do get their hearing loss addressed and provide older adults with hearing aids, you can actually change their healthcare use. So that was exciting to see. So what are some of the other strategies to also help with communication? So this is an area where I spend a lot of time, not only just from education, research, but in clinical areas as well. And so where I work at the Dexter Health Center, we have a deaf health clinic. And so this is a clinic that really focuses on trying to do optimal communication try to think about accessibility. So we work with roughly about 150 deaf signers, and we have a measure of how many hard of hearing individuals we have. It's a much larger group, but this is a clinic that's really been tailored and really structured to be a model clinic. And we do what's called integrative care management. So we have a social worker who is also fluent in sign language to work with me and another provider. And so hopeful to have a lot of warm and cold handoffs. So she is also able to help with a lot of the psychosocial needs. So one of the things that we do notice is that for deaf, especially deaf signers, and still to some degree for those who have later onset of hearing loss, is that the psychological impact. So again, there's a lot of interpersonal violence, a lot of mental health disorders. There's a lot of misdiagnoses as well. So these people don't really have great mental health access. So that's something that we are trying to address in our clinic as well. So in terms of the in-person communication, this is something that we hear time and time and time again. So for deaf and hard of hearing individuals, if you look at common themes that are brought up, it always seems to go back to communication breakdowns. So the communication breakdowns really has a cascade of events that are often negative. So one of the things that we have seen in several articles is that the communication breakdowns often will cause some medication misunderstandings, confusion, and as a result, if you don't really know what you're supposed to do, you are less likely to follow through on the treatments. So the adherence also goes down, which has, again, an effect on the management of their health conditions. But misdiagnosis is very rampant because if you can imagine, we have poor communication, you're going to more likely misdiagnose people. So a lot of what I do in primary care, family medicine, roughly about 90% of the diagnostic ability really goes back to the history taking and the communication, not necessarily physical exam and diagnostic imaging and so forth. So by having these misdiagnoses, communication breakdowns, it's not uncommon for people to actually struggle with poor, hold on a second, I'm getting an update about updating software. So a lot of people end up getting mistrust. And so that also, it sort of creates another rift between their provider and also the patient. So this is a struggle because if you have poor, you're not very confident, you have poor satisfaction with the provider, what that ends up doing is that it shifts and you're often seeking emergency care through the ED rather than getting regular care, primary care, or preventive services too. The other thing that we did a few years back, we looked at health literacy, and what we found is that deaf individuals were 7 times more likely to have inadequate health literacy. So that was a huge jump compared to the hearing peers. And there is also a more recent article, and we have seen this, but not published yet, but a couple of publications have already come out looking at those with older onset of hearing loss still have higher risk for inadequate health literacy. So it's important to understand that there's going to be health knowledge gaps, it could be health literacy issues as well. And this is so unfortunate because when you really think about, we're already now 30 years past the Americans with Disabilities Act, we still to this day are very inconsistent with how we provide accommodations. And accommodations is not just providing a sign language interpreter, it can be in some cases captioning, maybe some amplification equipment and so forth. But we have largely disempowered, we have largely put the onus on deaf and hard of hearing patients. They are often resorting to pleading, trying to get services, which has been unfortunate. And there's not much literature right now on how well we comply. So a lot of these are more hearsay, but there is one article that's provided in England, and they have a very similar structure on the requirements for providing interpreter. And this study actually looked at a group of primary care providers and a group of deaf individuals and looked at when they go to primary care appointments, how often do they get interpreters? And what they found is that only 17% of these deaf individuals actually obtained an interpreter for their visit. were provided. And what was ironic about it is that, and this goes back to lack of training, awareness on our healthcare workforce, but be truly equipped and be able to effectively work with these individuals. There will be probably more publications coming out. I know one of my mentee is actually looking at this and found, again, unfortunate numbers on how infrequent the interpreters are provided. And he looked at the emergency department, which generally they tend to be better, and even dismal numbers with that as well. Um, yeah, hold on a second, just looked like it froze, so. Give me 1 second, just trying to reboot this here. Are you guys able to see it? It's coming and telling me that the screen share is failing right here. Are you guys able to see it? If anybody could provide a chat or captioning.
Yes, we can still see your screen share.
Okay, perfect. Okay. All right, sorry for that technical issues there. So I wanted to talk about just some of the strategies that help with facilitate communication with deaf and hard of hearing individuals, and just kind of highlight some of the things that we do at the Deaf Health Clinic. And so the first thing is, so really just thinking about, we want to really just lift all boats. So we want to use the universal design inclusion principles and really try to apply it in a clinical area. So rather than just having to scramble and make it work for one patient, why not have it structured in a way we apply these principles universally? And it makes it easier to have these milder or smaller ships to provide the accommodations. So what we have done and what I try to teach is these provider-based communication strategies. So obviously, one of the first step I would tell my medical students, other residents, or even other faculty members is that we need to be humble. We really need to understand that we are often not the experts. So we have to understand that the patients are usually the experts on how to achieve effective communication. And that's not an easy thing for a lot of providers to understand, is that we need to take a step back, understand, and see what kind of accommodations are needed. And it's not always an equipment or interpreter. It may be just simple things like make sure you face me. Please remove the computer so it's not in between us. Make sure there's adequate lighting. So it can be mild things like that. The other thing is it's also to speak clearly at a normal pace. That can be super helpful. And then really just facing patient, trying to make eye contact. And so what that's actually really helpful because I used to have to type my notes when I was talking with patients. And I never really liked that because I also need to lip read. I need to have eye contact, and patients like that. And so, and I would always have to feel I got to catch up with my notes later. So one strategy until this COVID pandemic hit us, we used a scribe. And so a scribe was a great solution. They would join, they would type out the note, and I was able to really directly communicate and work with patients. So just really being proactive and creative on how to structure the environment so you're actually with the patient rather than more interacting with the computer screen. And so that was super helpful. The other thing I also encourage um, providers is to really identify patients who may be at risk for communication breakdown. And so the way you could do that now with electronic health records, I'll show you an example in the next slide. So we have ways to kind of flag it. You could put like a note, you could put it in the problem list and so forth. So it's important for the patient, the patient's provider to know ahead what to, so they can plan and also include the staff to make sure that the appropriate accommodations are there. And then the other thing is using visual aids and pictographs. So remember I talked about health knowledge, health literacy for many of these individuals can be lower. And so these are great strategies. And this is really a good universal strategy to help everybody. We all tend to do better when we have more resources, visual aids, medical terminology, especially jargon, all of that can be pretty confusing. And so it's a good practice, and I try to incorporate it with everybody, and I encourage others to think about that as well. The other thing that is not commonly done, but is super useful for deaf and hard of hearing individuals, is to think and assess about patient comprehension. So the way to do that is think about like teach back, teach to goal. I generally also try to do a summary at the end, so it's helpful for them to understand, okay, so these are the problems. What is expected for me to do next? So do I have to get lab work? I have to pick up a script. But the teach back and teach the goal are two other extra steps to make sure, do they understand what kind of problem? Can you tell me that problem? Can you tell me what you're supposed to do? And so that's super helpful to assess comprehension in a non-threatening manner. And that's something that we try to do as often as possible, regardless if they have a disability or not. The other things that are more equipment, we use a door knocker. I used to have one that was wired in my old clinic. We have one that you can hang on the back of the door, knock it, and there's a light that goes off. And even simple things like that are not well thought out, but they really could be so huge for patient satisfaction and comfort. So you can imagine if somebody is deaf, they can be easily startled coming in, and they may be in a vulnerable state. So it's super helpful to think about having it where it's easy for them to feel comfortable, have a visual aid. And then we don't have this in our clinic, but we are doing this in across the hospital, trying to encourage personal sound amplification products. So there's things like the pocket talker, which is a picture there, is helpful because keep in mind that 4 out of 5 individuals with hearing loss don't have a hearing aid. And so these are useful tools to help provide some assistance for those who are mild to moderate hearing loss. So keep in mind, these are not great tools for those in the what we consider moderate to severe all the way to profound. They generally don't benefit much from this. But the bulk of our population with a hearing loss is going to be in that mild to moderate, so it's a good tool to have. So I mentioned about flagging in the chart, and we're going to be doing a relatively large upgrade in October, which I'm excited about. And so this will take it to a whole new level. So right now, this is more basic, but we're going to be moving to a disability needs like a box. So have the type of disability that they may have, but also what accommodation or needs they have. So for example, if they have low vision, they can check that off, and they may need to have additional, maybe have to have a large print. So that's helpful to have and allow for the providers, the teams to prepare for that patient. But currently, until we get to October, these are some of the things that we have where we can actually do a little sticky note, which is the first box on the top. And I could put special, things that the patient needs and feels is helpful for effective communication. We can also, in the other box on the top, is the preferred language. So this is usually in the case where there's a deaf signer, they can have a different language, but it's also applicable for somebody with limited English proficiency, just to help to arrange interpreter needs. And then the problem list we're trying to do better is to document and highlight that they have a hearing loss. So having it multiple areas makes it easier for the provider to be more attuned that this is a person with a hearing loss, so that they're going to be hopefully better in facing the patient, work with some of the communication strategies that I outlined earlier. So from a system-based communication, one of the things that I will emphasize is that when disability is part of the diversity equation, I tell people that don't forget we need to have a workforce that's really representative of the patient population. So right now, we have very few people who are health professionals with a disability. And so we need to have a diverse team, and that includes providers and staff members who have a disability. And when we do that, we're going to have a diverse workforce that's actually going to be both empathetic. They're going to have their life experiences. They're going to often provide novel and creative solutions to address some of the barriers that I discussed earlier. So emphasize that, be an advocate at your site, and make sure that disability is part of that diversity equation. And then the other thing is establishing interpreters when needed. So you need to be proactive. Interpreters are so in short supply, and so we need to be proactive in scheduling in advance or schedule as soon as possible. We are fortunate here. We have an interpreter department, so we have medical certified or trained interpreters. So I really encourage people to think about having interpreters who have that medical background or training, because that really can make a huge difference in making sure that the communication is smoother. They understand how to convey medical terminology appropriately. The other thing is just really standardizing patient check-in and check-out. You can imagine, I mean, all of us struggle with how many forms we get, how complicated these forms are, even with insurance. So we have a long way to simplify it, and we're trying to simplify as much as we can in our clinic as well, to make it more of a bulleted point, get rid of some of the excess language, try to simplify it to a lower grade reading level. And so that's another helpful step. The other thing what we do with our healthcare staff and our clinic is that we try to get them to be proactive about documenting. So if there's a patient that has a hearing loss but does not sign, we need to document that. Or as a person who signs, make sure that interpreter is available, or to schedule an appointment with me or my team who could sign. And the other thing is really just setting up communication accommodations, well in advance, so that we don't have these last minute scrambles. The other thing is we have now developed a number of handouts, laminated sheets that has been helpful. But the other thing is also getting these two-way, what we call UB Duo. We have several of them. The interpreter department has some of these for kind of trials for our clinics. So we're trying to get people to use these two-way, sort of like a teletypewriter that communicates with each other. They're not cheap. They can be up to $3,000. So we are also experimenting with having tablets where you can interface and be able to do that. That's on hold because of the COVID pandemic, but we're hoping once this resolves that we'll have cheaper solutions to be available across the Michigan Medicine healthcare team. And then the other thing is what we have done, again, up till the COVID pandemic hit us, we were doing weekly sign language instruction during our lunch hour. And that was fun, but it was also really helpful in getting them to be conversational in sign. And that was super helpful to get some of our patients to feel comfortable. I mean, even just a deaf signer coming in, being welcome or greeted, even with some basic signs, and understanding the caution is that that does not replace a fluent healthcare provider, or does not replace the need for an interpreter, but it's really helpful to be more welcoming and more comfortable for that patient. So another strategy we did with another clinic, I mean, not another clinic, but another research project, and we did this across all of our Department of Family Medicine clinics, is that setting up a alert. So we had an electronic health alert that fired, and just simply asking, do you think you have a hearing loss? And this was done to help us to be more attuned that this is a person with a hearing loss, hopefully understanding they're basically at risk for communication breakdowns, but also helpful to if they need further testing or referral for hearing aids, that can actually streamline that process. So it was helpful not only to improve how well individuals with hearing loss were documented in our chart, and I think that was a huge first step, but also getting people to have access to equipment, hearing aids, when they're able to. And this is something we did initially as a research project, and now we have it across all of our clinics, and we continue to use them to this day. So all of us are living through this COVID-19 pandemic, and unfortunately for deaf and hard of hearing individuals, the disparities have worsened as a result. You can imagine everybody masking. It's also, I mean, it's been difficult for people like myself. Going to a store, everybody has a mask on. Very few people have what we call the clear mask. And this is also marginalized, isolated many of these people, even when they're in a healthcare setting. Initially, for the first actually it was almost 3 months, where interpreters were not even allowed in person. So they had to do more remote call in through like an iPad or a tablet to be able to interpret remotely. So there was a lot of very quick changes, a lot of unfortunately falling back to the old days, what we had before the ADA. So we really had to be very creative very quickly, not only here in Michigan Medicine, hopefully across the country in many of our hospital settings. Think about ways we can still overcome some of these barriers, but still apply a lot of the safety guidelines that have been set in place to protect us. And so we'll talk more about this in a second. So one of the things, obviously, is that we have moved largely to a virtual care. So now we have kind of moved back a little bit to in-person. So I'm kind of doing more of a 50-50 split. But virtual care appointments was really a boon to allow people to have access, but in a safe manner for many of the common medical issues. But what the problem came up is that virtual care in some cases can also be marginalizing, can be difficult for deaf and hard of hearing individuals to navigate, whether they do just a simple phone visit or they do something called a video visit. And a video visit many times did not have captioning or cart inserted with it. Sometimes that was because the video platform that they used did not allow the insertion of it, or maybe it was the provider was not aware how to do it, or the system did not provide captioning or cart services there. Here in Michigan Medicine, we do insert cart for those who need it into our Zoom video platform. So last week we moved back to Zoom, and Zoom is available through our electronic health records through our portals. And so that's given us a lot more flexibility. But the other important thing is that what I've noticed, and I'm trying to get other providers to avoid doing, is that for a deaf signer, what they're doing is they're often calling through the video relay service. So that's a free service that's FCC covered and allows for an interpreter remotely to be help to facilitate and interpret a phone call. But keep in mind that these people, these interpreters, are not medically trained or medically certified sign language interpreters. So there's going to be a risk for communication breakdown, misinformation, and so forth. So we need to try to use our medical interpreters as much as possible. And so we try to get everyone to use a 3-way video visit. So what's nice about that is that you can actually have multiple parties. It doesn't have to be limited to 3, but generally we call it 3-way, where we have a patient, provider, and interpreter, and you can see everybody's window at the same time. And the same thing with cart as well. So that's been super useful to try to make it more equitable. The other thing is important is that video is rich when you think about from a simple telephone visit. I can see the person, I can see if they're clinically well or not, and then I can also see their home environment. I mean, you learn a lot more through these videos than just a simple phone call. The other thing is what I try to do is try to use these video visits because it's a great way to build provider rapport. So if you could see the doctor on video versus talking to the doctor on the phone, that also seems you get a better connection with the doctor. And so the relationship tends to be deeper. So this is an example of a three-way. So we have a medical staff interpreter in the bottom signing sick. And so I'm pretending I'm talking with the patient, saying, you're sick. And so the patient, is also communicating back or talking. And so having this structure where there's a three-way video visit call is something that's usually easy to incorporate in most of our video-based platforms, such as Video, is VYDIO. There's also, there's Zoom. There's a couple of others that are commercially available right now. They do have some license or contract agreements that you have to make sure that that's upfront, that you want to have multiple parties be part of it. And sometimes there's a little bit of a cost addition to that. But it's important to be upfront and try to get those arrangements set. But it's a super useful way to ensure equitable access and allow the incorporation of our staff interpreters too. So the other important thing is the in-person patient care. So in terms of clear mask, there are only 2 FDA approved clear masks, and that's the Safe and Clear communicator mask and the clear mask, which is, so the first one on there with the 2 ladies with a smaller viewing window, that's the communicator mask. The second one below is called the clear mask. That one just recently got FDA approved as of like literally 2-3 weeks ago. And then keep in mind that these are not available for aerosolized conditions. So if you're intubating a patient or something where there's going to be high risk of COVID particles to come out in the air, then you have to use something called a powered air purifying respirator. These are not cheap. They're hard to get, but that's super helpful for, you could take the mask off. It has a complete shield. It's keeps it where you have your own little respirator. So that is also another way where you can provide access in a ICU setting or something where it's more complicated. The other thing is the in-person patient care. We lost a lot of our interpreters in person, so we had to move quickly to these pool units to allow people to be able to access interpreters remotely. So we were able to get the interpreters through these iPad, and this was kind of a quick fix. The interpreters are now allowed back in person because of the numbers of COVID cases in our area has come down, fortunately. But they're also given personal protective equipment. We were in very short supply earlier, so that was part of the reason why they were kept out for safety reasons. So we have these mobile units. And one of the things that we realized was super helpful with this is that now we have these mobile units, and it's great for, we have a patient that comes in, does not want to interpret with me, but they do a checkout up front. Now we could just quickly dial up these interpreters just for a quick check-in and check-out. And so that's nice to help with more ancillary communication. We also, sometimes for like urgent care appointments, something that happens without advance notice, these can be good backup options too. The other thing is the deaf blind was one that was hit especially hard with this COVID pandemic, and they still are because of the need for tactile signs. So these people, we really had to lobby and advocate hard that the interpreters still need to be allowed to come in, and they had to get personal protective equipment just like any doctor or a healthcare provider would get. And so they needed to receive training, but that was the only way to really help for these deaf blind individuals to have accessible communication. For other individuals who have hearing loss, there's what we call communication boards. Some of them are called boogie boards, and these are, these can be useful for people who have hearing loss but are non-signers. Just need to have some quick, communication back and forth, talking about like a medication, for example, like how to use it. And so that was another strategy that we are incorporating too. The last thing, it seems so simple, but signage is so critically important. So having these little signs on a chart, also having it available on above the patient's bed, on the door, the more places you have it, the better prepared you're going to have these providers to understand, oh, okay, so this is a deaf and hard of hearing individual. What can I do to help facilitate the communication? So don't forget signage. It's easy to print out and put it on, in the high visible areas too. So there are some personal devices now with smartphones. Many of us own these, including the smart tablets. And many of these apps are downloadable for free. They may have a small fee if you use more than usually about 5 or 6 hours per month. But these automatic speech recognition are really helpful, especially if you're out and about in the community. So like Google Live Transcribe, Otter.ai, Ava, Interact, Live Streamer. These are just different tools that we have available. And I encourage deaf and hard of hearing individuals to have them as a backup option. These are not intended to be replacements for accommodations in the healthcare setting, but they're useful just to have just in case you're in a pinch, failure of accommodations or so forth. But it's nice to have. I even use it, especially if there's a meeting and it's not captioned or, I'm kind of scrambling to figure out what to do. They can be very helpful. The ones for sign language, there are a couple, they're not readily accessible, but there's a couple where you could do a fee for service, call interpreters remotely through your phone to help you through community needs. Again, it's not intended to be a healthcare setting replacement. But these are a couple options to consider. And so if anybody has a hearing loss, encourage you to check out these apps. They're getting better and better every day. I mean, they're not as good as a live card or captionist, but they're getting there very quickly. The other thing is what I have done over the last few months is really take a minute to try to get people to be proactive about their healthcare. And I have done that more so given the COVID pandemic, since it's arrived. It's really just trying to get patients to be proactive, trying to empower them. And I tell people, don't be shy. You've got to advocate for yourself, and you need to tell each and every individual on the healthcare team that you have a hearing loss. And so the more you could do to kind of prepare for these visits, and I tell a lot of my patients that unfortunately some of you are going to go to the hospital because of COVID. And so it's helpful to think about having some sort of a like a bag ready to go with, have some copies of your medications, your list of medications, medical records, anything to really help with the communication. And then the other thing is when you have outpatient appointments or procedures, it's always a good idea to check in ahead, ahead and just see if the accommodation is set in place. Sometimes, things fall through the cracks, so it's helpful to get that arranged. And then the other thing is in terms of communication access plans, this is provided through the Hearing Loss Association of America. I encourage you to take a look at it. It's really it's a great model to think, and this is also really applicable for other types of disabilities as well. So these are very similar to what a lot of moms and dads think about, like a birth plan. So having a communication access plan, you write out what your needs are, what works, and then you give it to the healthcare team, and they usually put it in your chart. So encourage you to check it out and take a look at it. And this is easy to tailor for other types of disabilities too. So there are some assistive devices too. Obviously, hearing aids and cochlear implants, many of us know about, but I try to get my patients to be aware. You got to think about bringing your charger. If you're there for a few days, you need to bring extra batteries. So those are things that sometimes we forget about. We're kind of in a scramble. So having that in your bag, ready to go, can be very helpful too. The other thing is for personal sound amplification products, these are not very expensive. Usually they could be less than $100. And again, useful for mild to moderate hearing loss, especially if they don't have a hearing aid. So it's something to have perhaps at every station or even at outpatient clinic too. And then certainly having these speech to text apps, again, not one to replace the accommodations that we're obligated to provide, but it's nice to have just as a backup if things fall apart. I think I'm amazed how much information nowadays is shared through the TV at hospitals. They're almost now sort of an information resource. So getting you ready for discharge, for example, or getting ready for a procedure. So it's important to think about having closed captioning as working on your TV so that it does not disadvantage definitely hard of hearing individuals while they're there. So the future is coming fast. So signing avatars is one of those tools that's going to be coming up in the next five to 10 years. And this will be huge for deaf signers, given that for some, English is not a language that they're comfortable with, and they may just prefer to communicate solely in sign language. And the signing avatar is one that I think will help provide another tool for them. And then the other thing is the improvement, the quality, and the accuracy with automatic speech recognition with many of these tools is rapidly changing. And I expect this is going to be probably even better than some of the live captionists probably in the next couple of years. The other thing is that we're also exploring the possibility of using wearable devices. And many of these smart glasses, well, it's not a new technology, it's been out for a little while, but having it where you can have built-in captioning or even having a small window for a sign language interpreter can be useful too. And that might be useful for places where access to an interpreter may be hard, or finding access to captioning services. So I just want to wrap up here and leave some time for questions and answers. And so remember that the patient is generally the expert on what works best with communication. So try to get people to be more aware, and I try to get the providers to be more humble about that too. And just to take a step back and say, but what works for you? Can you teach me instead? So that would be very, very useful. So I'm going to stop there. I have my contact information, and we can open up. I'll stop share in a minute. So some of you guys might, if it's useful to write it down, and then I'll take a look at the chat window.
All right, you want to help me real quick, Mom? Kill the gophers? Were you watching? This last one.
I'm sorry. Okay. So I see there's a first question here. Is how do you do it safely for deaf blind patients? And so the way to do that is that you need to have the interpreter. So if there's a situation where you are concerned that the patient has COVID, or maybe in a highly aerosolized environment, then what I would suggest is that you need to think about having the interpreter do personal protective equipment. So they should gown up. They should do everything that you would expect for a healthcare provider. So the tactile sign would be through a gloved, like a surgical gloved hand. Well, that's not perfect. It does provide an avenue to allow them to communicate. Are there any other questions? And it looks like somebody does use the pocket talkers at the VA and works well for our veterans. And I will say the VA is actually one of the very few places that can actually get hearing aids covered in full. So it sounds like you guys are also being very accessible. But that's certainly a system that I think is sort of our model to get full coverage for hearing aids. So I'm sure you probably know more about that. Yes, I agree. It does work well for those the mild to moderate hearing loss range. So somebody asked about having a certified deaf interpreter. So there are very few places in the country that does this well. However, it's super useful, especially when we have deaf individuals who are not as proficient or maybe had language deprivation, for example. So the certified deaf interpreter is a great bridge to help improve understanding. So they come together with a sign language interpreter. So you have a sign language interpreter, you have a certified deaf interpreter. So these are deaf individuals that can allow for more flexibility. They tend to do a better job in engaging people with language deprivation. So you're having two interpreters. So many healthcare systems often balk and say, well, that's not needed, we're already accommodating. But I will tell you though, with language deprivation, many of these people definitely do need to have the CDI. And there is one place right now that does best with the inclusion of CDI, and that's at University of Rochester. They have actually certified deaf interpreters on staff. And so if you want more information, that's definitely a model to look at. Here at Michigan Medicine, we're trying to get to have that same model where we have one certified deaf interpreter to be on our staff. We haven't gotten there yet, so we're trying to work on that. But yeah, I totally agree. It's something we need to do. Unfortunately, is not done in many places. I know it's getting late for a lot of people, so I'm sure people are getting tired. But if there are additional questions, or if you prefer to ask these questions privately, feel free to email me. Happy to address them.
Okay, well, thank you, Dr. Mckee. And if there are no more questions, I think we're good to go. Thank you, everyone who came.
Yeah, there's also here about sending the PowerPoint. Jenna,
Yes.
I can send it to you. It's probably the best way to do it.
Yes, that would
Yeah.
be wonderful. Thank you.
Okay, great. Well,
All
thank you
right.
for joining. I think this is great to see try to improve the awareness on disability health. So I appreciate Jenna you taking the lead on this.
Great. Thank you, everyone.
Thank you very much.
Thank you, everybody. It was wonderful.
Thank you. Great training.